This conference will now be recorded.
So,
Say,
good
Rick,
evening.
excuse me. I have something to bring up if there's time.
Yeah, we'll get around to everybody. Take
Not a problem.
Take your time. Take
Not
your
a problem.
time. Hold your horses, everyone. Where was I? Oh yes, I was saying that this is the June the 1st high risk call, high risk recurrent advanced call. If anybody listening is confused why you're having a call on June the 1st, it's because first Mondays and second Tuesdays follow each other this month, so we've had to switch around on our schedule, and as such, we will be having our calls on the first and third Mondays at 8 o'clock and the first and third Tuesdays at 6 o'clock. Welcome everybody. Most of you know that we record this call. If anybody has
second and fourth
issues,
Tuesday. You
what was
first,
that?
You said first and third Tuesday, second and fourth Tuesdays.
No, Jake.
Oh, this
Please
month you're talking about.
Please don't confuse everybody.
I'm sorry,
Okay?
I'm confused.
Otherwise, we're gonna have a new Mute-iner. Okay. So yes, again, this month it's first and third Tuesdays, just this month, and then we go back to regular scheduling in July. Okay. I know that we have two new gents. We have Harry, who lives in Reston, Virginia, along with some other Virginians and some other Restonites. And we have Blee, who came in last week, but we didn't have time to do an intro with him. So what we're going to do is we'll start with Blee, because he was able to hear what we do last week, and then we'll go on to Harry, and then when that is all done, I will do a round robin to see who needs time today. So Blee, I'll ask you a few questions, even though I know a little bit more than others, and I do know that you've had the good fortune of talking with Jerry Deans, who's just incredible. Another Virginian, but not in, and you're a Virginian, of course.
I'm a Virginian.
Run with you. What do you call yourselves? MDVs, DMVs, Delaware, Maryland, right. Virginia, right?
It's in the water. Yeah.
It's in the water. Okay, so let me ask you a few questions. That way we'll move through quicker, and then we can get into your treatment. So Blee, as I recall, you're 61, is that right?
Yeah.
And you live in Charlottesville?
Yeah, Charlottesville, basically. Yeah, just outside of Charlottesville. Yeah.
Yeah, Charlottesville, VA.
I'm on.
And when were you first diagnosed?
Per biopsy in January this past.
Okay. And what was your Gleason score and your PSA level when you were diagnosed?
4+3, and I had not gotten a PSA in a couple of months. They stopped drawing it, but my last PSA was about
right there. It's right. No, 0.3 miles. See, 0.3.
Okay, if we can, where's my chief mutineer?
Mutineer, I like that.
Yeah,
I already got him. Rick,
leaving on the switch there, mutineer.
Forward 2, I already got him.
Okay, thank you very much.
I yield my time back. Go ahead.
Thank you. We know we're in Virginia when we get those sort of when the peanut gallery starts giving us those comments. So what was your last known PSA?
My last known PSA was just shy of 13. That was early December.
Okay. And where were you going for treatment? And where did you have your biopsy done?
I initially, well, I've had a lot done. Initially, I went to the University of Virginia. And then I went to a fella in private practice here in Charlottesville, and then I ended up in Richmond. So now I'm on my fourth urologist. So I'm a little picky.
That's good. There's nothing wrong with being picky. And so is your current doctor the one in Richmond?
No, well, technically, I guess, because I haven't hit my appointment with my fourth one yet, which is at the end of the month.
And where will he be?
Charlottesville.
Oh, Charlottesville. Okay. And these are all urologists, is that right?
Yes, and I've got one rad onc.
And you have a radonc lined up, huh?
Yeah, I've already met with her twice. Yeah.
And where is she?
She's in Charlottesville as well.
Okay. Great. Have you to date had any type of scanning?
I've had no scanning, but I've had a hell of a surgery. Yes.
So, so in other words, when you say you've had a hell of a surgery, what treatment have you done so far?
I had a robotic prostatectomy early March.
Okay. All right. And that was done by which of the 4 urologists?
Number 3, Richmond.
Richmond. Okay. And he was in community practice there in Richmond?
Very large practice based in Richmond. Huge. Yeah.
Okay. Did Jerry know him?
Jerry knew of the practice.
He knew the practice. Okay. Now, what did they find in that RP?
They found 80% of my prostate was tumorous. 5% was grade 5. Everything else was maintained at 4+3. I did not have clean margins. I had bladder neck invasion. I have lymphovascular invasion, but my nodes were clean. And that's all we know right now.
Okay, so there was bladder neck invasion. How about the seminal vesicles? Were they clean?
Both of them, they were gone as well in the process.
They took them in the process, but was there cancer in the seminal vesicles? There was.
Both, yes, right and left, yes.
Okay, and you had positive margins.
I'm a T3B, I think.
T3B, and you had positive margins.
Yes.
Okay. Okay. And they've done, but they haven't done a bone scan or a CT scan on you yet?
Yes. The rad onc did a bone scan. It was negative, except I need some dental work. Yes.
So bone scan negative. And do they see any cancer in any of the lymph nodes? I think you said no.
No, they pulled a couple and they were clean.
Okay, that's good. Okay, just a couple more questions. Have you had any genetic testing done? Do you have any genetic history of cancer?
Yeah, well, I'll get to that in the other, but yes, I had genomic testing. I did a Decipher, and I'm a 0.61.
Okay, I mean, you'll have to fill these guys in because most of these guys aren't that familiar with the early testing. That means it's likely to spread, doesn't it?
Yes, it's technically high risk. It's on the low end of high risk. And Decipher it takes your tumor cells and compares it to a bank of tumor cells, and they look down the road of what happened to folks who had the tumor mix that you have, and how did they do, and that's how they categorize it. Yeah.
Okay. And what about any testing for mutations like germline mutations?
Right, it's cooking now. Yeah.
It's cooking. And what's your family history?
Well, that's part of what I'm here to. I got a couple of questions for you. I don't know. My brothers and I and our cousins are the longest living people in my father's side of the family. And so when I look through, I'm an ancestry.com freak. And when I go through there and I find relatives, they're all of that line, they're all dead by 60. My dad died at 49. His sister died at 42. People don't live long in my family. So that's part of my decision making coming up, actually.
And is there any history of cancer on your father's side from that you're aware of?
None. Nope.
Well, so one last question, which is, how did you hear about us? How did you find Ancan?
Waiting for my Excel spreadsheet to save. Surfing the web, and I was trying to drink up everything I possibly could, and quite by accident, I think, stumbled on you guys, and
Okay.
have been very appreciative of your help.
Pleasure. So actually, what I should have asked you and I didn't is, why don't you tell us also before we'll turn it over to the guys in a second, but tell us what your plans are right now for your follow-up treatment.
Well, they've been telling me to. It's funny because my rad onc, who's marvelous, she wanted me to start ADT right away, and she wanted me to start radiation as soon as I was fully healed, which I'm not back to. You guys got to tell me this stuff. She was telling me that you be as secure with your plumbing as you can be, because radiation tends to stop you in that progression. And so I've had a little setback in the last couple of weeks for some reason. I don't know why. And so I don't think I'm quite there yet. So I think if I go for radiation, it'll be around the 1st of July or so. I do have some reservation about that. And that's why I'm here, principally, for very convoluted reasons. But I'm just not sure. So this PSMA radical isotope, whatever it is, I talked to my rad onc today, and I said, find me someone, please. I want to see where it is and how big it is. On my follow-up visit, my PSA was undetectable, but everything else was as it was. And my surgeon was trying to say, "Oh, yeah, you're off the hook," and then my rad onc goes, "Oh, that doesn't mean anything." And I get a lot of mixed messages. So I think what I understand of the PSMA, and I'd like to hear from you folks, is it's pretty definitive. Tells you where and how much and things like that. So I'm looking forward. Hopefully, one of my questions again is, how long should I wait?
Right.
I've got a testosterone of 82, just all by myself. So I'm hoping that's somewhat protective, unless, as my sister, who's a medical oncologist, says, well, it could be one of those cancers that doesn't need testosterone to grow. So
right.
Very interested in the PSMA.
Yeah, I mean, the only thing I would say there is that given that you had a PSA as high as 13, that with the 4+3, that's fairly normal. I mean, you're not one of these guys who shows with a PSA of 4 and a 4+4 cancer, which we see, and they tend to be the ones that are more independent. But what I'd like to do is really allow Peter to kick this one off, because Peter Kafka, because he sees the most of this type of recurrent disease with our low intermediate, and he's probably the most familiar in how quickly you should follow up, not to mention he had to follow up himself, and so he's probably got some thoughts on how quickly you follow up. I will just say one very quick thing about the scanning tests, which is that you're unlikely to see very much on the scanning tests until your PSA is north of around 0.65. Doesn't mean to say you won't. You can get results between 0.2 and 0.65, but you really have to allow that PSA to get up to a certain level in order for the scanning tests to even work.
So that really confuses me, because how can they tell me I have invasion of my bladder neck and my lymphovascular space bed if I don't have a PSA? It's got to be detectable. Somebody detected it, right?
They've seen it through the margins. They've seen it through the surgery.
So they didn't see it on the bladder neck. They saw it because that's where that margin would have been.
Well, I don't know, and we can ask them. We've got a couple of doctors who are peers who are on the call, and we can ask them. But my guess is that somehow or other, through the pathology, they've identified where they see the cancer. But they that's where they're giving you that result from. But you won't physically see it on a scan. It's highly unlikely with 0.1. Peter, why don't I let you talk to Blee about when to follow up and some of these issues, and then we'll throw it open and we'll get some feeling from some of the medical professionals too.
Okay. Blee, I just want to make sure I understand. My name is Peter, and I live on Maui, but right now I'm parked in Minneapolis. It's a long story, but
I'll bet it's a good one.
I don't know. Did I hear you right when you said that after post-surgery they graded you as 5% of Gleason 5?
Yeah, you know, they broke it down on the path report, and it was like 80% 4+3, and then there was 5% grade 5. Yeah.
So they might categorize you now as a 4+5 and not a 4+3. I'm just saying that.
Yeah.
If they did
When I asked my rad onc about that, she said it doesn't quite meet the threshold to. She just said your prostate was chock full of cancer, basically what she said,
Right.
but it hadn't reached some level to change my Gleason.
So Peter, they would consider that to be a 4+3 with a tertiary 5.
Tertiary, that's it. Yeah.
Okay, interesting. So I mean, as you say, you've got some problems. You've got some urinary issues, bladder issues, and so forth.
Yep.
You know, I don't know if it was the expertise of the doctor or just the physical conditions that you had that caused this. I can understand the reluctance of a radiation oncologist to go at it too fast if you've got some bladder connection issues and so forth, because that could really be debilitating. And because of that, I can understand why they want to put you on ADT to try to calm things down, to get you in better shape and keep the cancer spread at bay until you have fully recovered. Most guys wait till about 0.2 or so to start doing follow-up radiation. I made it about 11 months. I knew damn well that I was going to go to radiation after surgery, but I had plenty of urinary problems before my surgery, but they were kind of cleared up with surgery.
Yeah, mine as well.
Yeah. So It's a tough question. I would for sure go with experts, I mean, rather than local people, because you've got a pretty delicate situation. You know, if you could not go to Hopkins or a place like that where they've, you know, where they've got, rather than a community type of place where they've got, you know, high class radiation oncologists, or even consult with a medical oncologist, because the medical oncologist is going to be the person who's going to be there long term for you, and you're going to need to have one of those at some point to work with. So it's a tough one. I wouldn't if I was in that situation, I wouldn't jump at radiation right away. The PSMA scan might be useful in your situation, but it isn't necessarily going to you know, be a final thing. I've had 2 of them for recurrence, two PSMA scans, and they were useful for me, and they led to treatment, but they've but I didn't do them right away. You know, I was my initial radiation was before the advent of PSMA scans.
So let me ask a quick show of hands. How many people on this call have had a radical prostatectomy? So I'm looking, Jeff, keep your hands up, and John, Pat, Joel, Carl. Okay. So, and Paul Frieda. So most of you have, if not all of you, have suffered some type of recurrence, because otherwise you wouldn't be with us. Don, what are your thoughts on, what advice would you give to Blee based on your experience?
So hi Bree. So I'm the former Reston also. And I'm not sure that this is advice, but rather just my quick story, which is that diagnosed in 2014, 4+3, 20 PSA, radical prostatectomy, seminal vesicle invasion, margin, and this was in Colorado, University of Colorado Cancer Center. They suggested that right away I have radiation and hormone therapy. So the prostatectomy was in April, and I started the hormone therapy April, May, June, July, August. So like 4 or 5 months later, and then started the radiation in either October or November. And the idea, and this was also, by the way, radiation on prostatectomy, prostate oncologists in Marina Del Rey in California kind of participated in the decision to do that. And the idea was to be aggressive and look for a cure. And by the way, my PSA after the prostatectomy leveled at 0.02, so never went to undetectable. And you know, the question is, was I overtreated or not? You know, because maybe I could have waited until the PSA started coming back up. But my thought was, you know, no regrets. At the time, I'd rather overdo it than underdo it. So, you know, and I would say I'm, you know, happy with the results of all that.
Sure.
And so
It's
you
a great story.
waited
Thank you.
6 months, did you say? It was March, and then you started your radiation around November, is that right?
Yeah, and it was again the make sure the urinary tract had healed before they started the radiation.
Right. Who else has experience in following up? Joel, did you have your hand up?
Yes, I did. I just had the prostatectomy, and that was it for me until the SBRT 8 years later, 9 years later.
Okay. So you didn't, anybody else have to follow up quickly? John Ivory, did you have to follow up quickly?
You know, I wish I would have followed up quickly. I had positive margins. I didn't have any other, seminal vesicle or any of the other issues. Sorry, I've got brain fog. But I waited. My urologist said it would be okay to wait till my PSA went up to about 2. So I waited till it was 2.2, and I'm not sure if I would have gone for the radiation right away. If that would have kept me off this call and kept me off the ADT, but such is life. So yeah, I had, if it's water under the bridge, but if I had had the choice, I would have gone for the, I don't know if they call it adjuvant or whatever it means right after the surgery.
Right. If it makes any difference to you, Lee, there is some recent research from just in the last,
I'm so sorry.
That's okay. Just in the last 6 or 8 months, that suggests that if you defer your early salvage radiation or adjuvant radiation up into about 8 to 9 months, it doesn't make a difference. Now, that said, we need to look at it again, and I think I have somebody may be able to track it down. If not, I definitely have it. I can send it to you later. And we'd have to look and see if the men in that study had seminal vesicle invasion, whether that was a factor or not. We do know that SVI tends to simulate more aggressive treatment. And my feeling is that certainly if I had SVI, I probably would be definitely following up with androgen deprivation therapy for a period of time. Whilst 82 is not great for you as a man, it's still high enough to feed the cancer. You need it to be a little lower than that to really feel comfortable. That's still not quite castrate levels. So I would tend to want to do the androgen deprivation therapy, and if I was doing that, I wouldn't be quite so concerned about the follow-up, about when I started the radiation. One thing I would say, well, maybe I should ask you, has the radiation oncologist told you what the field of radiation will be?
No.
So
She was ready to schedule me for a measuring session or something, and that's when I brought up the PSMA, and she said, well, then, I'll try to find one for you, but I'd rather not start any treatment and get your PSMA, so we have a good starting point, because I have no imaging other than the bone scan.
A couple of things. First of all, there was PSMA available in Norfolk.
Right, they closed down. I called Princess Anne or Centera, and they've closed that research down.
Okay,
So it's
well,
not ready.
Guys, that the approval, and if you read the press release of the approval of the 18F PSMA ligand, they said it will be available immediately on the East, all over the East Coast.
We're looking.
The first thing is it's not going to do you a lot of good until your PSA rises. So we've got to wait and see. But I think a more important.
Is it helpful to know that it's not picking anything up?
Hold on a minute. Let me finish, and then you can come back on me, okay?
Okay.
We know that you've got to have a certain level, because we've seen guys try and get PSMA readings with both 18F and with gallium-68. 18F is better, but you still don't get a reading at 0.2. We've seen it. So you can do it, you may do, but it's really a crapshoot. The second thing is that it's very important to know what your radiation oncologist is planning on shooting at. Is she just going to shoot at the bed? Is she going to shoot at the pelvic girdle? Is she going to include all your lymph nodes?
I don't know.
We need to find out. My belief is, and there's more and more research coming coming out to support this, and this is what I had, is that pelvic girdle radiation is the gold standard. The wider that field, the better you are. And, you know, whilst there is some downside, any radiation oncologist that only focuses on the prostate bed and just the lower lymph nodes, I don't think it's enough, but it's very controversial. So there's no right, there's no wrong. I can only tell you what I would do and what I did. So we've got 5 more minutes that we can spend with Blee. Blee, first of all, you wanted to come back. You had a question.
Well, is it significant if they don't find anything? I mean, if I go in and my PSA is too low, is that information to help
Not
decision
really.
making?
Not really. Because we know that when you've got a 4+3 in a tertiary 5 and seminal vesicle invasion, the likelihood is that you've got micrometastasis that we cannot see, but it's out there somewhere.
Right.
And so it
So
needs,
I'm sorry.
it needs treating. So the best way we know to treat it is with early salvage radiation and with hormone therapy. Now, in your case, is the hormone therapy going to be 8 or 9 months or longer? That again is highly debatable. Probably worth getting a second opinion from another good RO, because 4+3 is usually 8 or 9, but with seminal vesicle invasion and tertiary 5, that would lead me to be asking, do I need to be on this for a little longer, 18 months? Because what you're aiming for is what I was fortunate enough to get, which was a durable remission. That's what you want. You can't be cured. That word isn't really in our vocabulary for your type of disease, but you can get it. You can get durable remission. Let me ask anyone else if they have any pearls of wisdom for you before we go to Harry.
Yeah, I'd like to make a comment, Rick.
Please, Mark.
First of all, I don't think the PSMA will be of any value at this point. I think with the seminal vesicle involvement, you definitely need to be on ADT at this point. And there are many, many men who have ridden out with just ADT and not gone ahead with the early on adjuvant radiation. Studies looking at microscopic residual disease really are inconclusive on whether you have to do it initially or whether you could wait. So I think in my case, what I might advise would be to discuss getting on ADT and then following the PSA. If it gets elevated to a point where you're likely to detect disease outside the pelvis or persistent disease in lymph nodes, then I think going ahead and doing the radiation would make sense. I think if you get on ADT and the PSA stays low, I'm not sure you're missing anything by holding off and going into a different form where it's not exactly active surveillance, but in a way it's just active surveillance on the ADT. So that would be my recommendation. The question that I would ask in addition to ADT with an antagonist, would it be wise to consider adding in abiraterone to really drop the level beyond detection? Right. Because I also agree that initially 50 was the range they shot for in terms of ADT. Now some people say you really need it below 20, and you may very well need the abiraterone to get it that low to be effective.
Right, and in order to get that opinion, you may well need to bring in a genito-urinary medical oncologist, of which there are available, but they're few and far between. I would probably suggest Fletcher in Norfolk, I think it's Fletcher.
Yeah, I spoke with that office today.
Yeah, I mean, I think he's as good as any. He's easy for you to get. He's aggressive, and he would be a good person to say, look, if I'm going to hold off, do you think I should be adding abiraterone given what I do? And you know, he's reputable, done a lot of trials. Dr. Mark, I have a question for you. How likely is it that they were able to say there was bladder neck invasion from the surgery? How do they tell that?
Well, they take out the bladder neck with part of it. So you're not going to tell that unless you have, you know, when you take out the prostate, you're going to remove the urethra, and how close that's getting, whether they actually resected part of the bladder neck. I'm not sure why they would do that unless they had a visible reference, or whether when they looked at the tissue, it looked more like bladder neck tissue. But you're going to see cells, and these are individual cells, and it's not likely going to be something that would be significant enough to show up on the PSMA scan, either before or now. The stuff that they see when the margins are not clean isn't going to show up. If initially the PSMA was high, or the PSA was high enough, they might have detected that it had spread. But at that point, we weren't doing early on PSMA scanning. So I don't, you know, I would think that they're not resecting the bladder neck unless they actually see something. And I think if you're having, if you are continent of urine, then it's not likely that they resected the whole bladder neck.
We're going to have to call it a day right now, but Lee, next meeting is Monday. Come back. We'll give you more time if you need it. You can ask us questions.
I will. I do have another perspective I'd like to bounce off you guys. Yeah.
Okay, so let's leave that till next time because we need to give some time to Harry, and we got to leave enough time to try and get around everybody, and we got to finish on time. Yeah, just a
Thank you all very much.
It's a pleasure. Just a heads up that we've got to close this room out at around no later than 5 of the hour because we've got caregivers coming in at 8 o'clock Eastern. Okay, Harry, you've heard the format. What I'm going to do is ask you a few questions, and
All
then
right.
spend the rest of the time batting around what you need to know and what people can contribute to your situation. So
I can be very quick.
okay. Well, let me go through these questions quickly. How old are you?
I'm 76. I'll be 77 in 2 months.
Okay. And you live in Reston, Virginia. We know that
Yes.
part. And what year were you first diagnosed?
Was diagnosed in 2015.
2015. And what was your Gleason and your PSA when you were first diagnosed?
Well, my PSA was 9.5. I don't know what my Gleason was.
Okay. And where were you going for treatment at that time? Who diagnosed you? Where were you going for treatment?
I was going to treatment with Dr. Lorraine, and he took care of me. And then I went to the Virginia Hospital Center for radioactive seed implants. I got radioactive seed implants at the Virginia Hospital Center. And then I got hormone therapy. And then I went to the Reston Hospital for 30 days, and I got 30 days of radiation. They said they gave me 30,000 rads of radiation, which was a lifetime limit for radiation. So I didn't think I would have any radiation, but I think I'm going to have more radiation now.
Yeah, I think that's not necessarily a lifetime limit. So you had seeds and hormone therapy and radiation therapy back in 2015. Is that right?
Back in 2015, yes, and it seemed to take care of it. My PSA numbers went down very low.
Let me keep going here. We'll get through it. That's the treatment I had, so I'm very familiar. How long were you on the hormone therapy for?
I was on the hormone therapy for 4 years.
you were on hormone therapy for 4 years from 2015 through 2019?
Well, they gave me one shot in 2015, and I don't think I got another shot. I just had the radiation and
Okay, that's what I'm
the
asking. So how long
yeah,
did
no,
they gave you one shot of radiation initially, right?
no, they gave me radiation for 30 days.
They gave you one shot of hormone therapy initially. I misspoke.
One shot of hormone therapy.
So
It was
my
it was
guess
a big needle.
right. So my guess is that you had Gleason 3+4, and they treated it with LDR and hormone therapy and radiation therapy. And then when did they do any scanning at the time? Did they do a bone scan or anything like that? Or
No, not at the time. What happened was I was supposed to go back every 6 months. I was supposed to go back this past June, but I didn't go back because of COVID. But I called them up about 2 months ago and I said I better come in and get checked. And he came in, they did a blood test, and I had a PSA level of 4.5.
okay, and
So,
when was the last time? This was in when did you say, March of this year?
yeah, it would have been about March. It would have been about March.
And when was the last time you got a hormone? When the last time you got a PSA before that?
Oh, it had been about a year before.
And what was it at that point?
It was very good. It was like 0.14 something.
Okay.
It was very low.
Yep. Got it. I get the picture. So sometime over the last 18 months, the disease took off and it went from 0.14 to around 4.5.
4.5.
And where are you being treated now? Who are you seeing now?
Well, they sent me in for 3 scans: an abdominal scan, they couldn't find anything; a bone scan, they couldn't find anything. Then they gave me another scan, which was a new type of scan. I don't know, it was a full body scan. It took 45 minutes, and that's where they found it. They found it outside the prostate.
Whereabouts?
I'm not quite sure. They said it was in one point outside the prostate, not too far from the prostate, and
But not too far. Okay,
I'm scheduled to meet a radiation oncologist at the Virginia Hospital Center sometime in the next 2 weeks, but I don't have an appointment yet.
Okay, so a couple of things here. My guess is what they did is they gave you something called an Axumin scan.
Yes, an Axumin scan. That's what it
That's
was.
what they gave you, and they found fairly local. They found local spread, and now
Yes.
they're going to be talking about how now. It'll depend on what sort of field they covered when they did the radiation originally. When you had that original 30 days. One thing I will say to you, which would be really helpful, is try and get for yourself copies of all of your reports. So like that Axumin report, ask them for a copy for yourself. The reports, the radiation oncologist report back in 2015, whoever did all that work, did you say, who was it that put the seeds in, Dr. Loren?
No, it was Dr. Poggi.
Okay, so and who did the radiation at that time?
The radiation was done under Dr. Laurent, but I don't remember him being there doing it. I just went to the Virginia Hospital Center, and they had a radiation center, and I went every day for 30 days.
But Dr. Loren is a radiation oncologist?
No, Dr. Laurent, I think, was just a regular, regular doctor. But Dr. Laurent died. Dr. Laurent developed bladder cancer, and he died.
Not good. Okay. I think we have all of the questions answered. Do you have any history of cancer in your family?
It's all over my family. Everybody in my family's had cancer.
Okay, have you had,
no,
you had
nobody's
germline testing?
no.
Okay, so you've got to ask for an inherited cancer test.
Okay.
And you can do that even with your PCP. But at this point, we need to know a little bit more about your mutations in order to treat you the best way. Okay?
Yeah, almost every relative in my family has had cancer.
So I think that it would be a really strong idea to, it's just either a spit test or a blood test, very simple, but you should be eligible if you have a lot of cancer in your family. What sort of cancer do you have in the family?
Well, my mother and my sister had breast cancer. My aunts had breast cancer. My father had brain cancer. I had a couple uncles with lung cancer. I mean, they're just bladder cancer, all types of cancer.
Right. So it's really, really important that you ask for that, and your doctors should have really taken that history and they should have done that already. And the reason is because whatever treatment you get, there may be additional treatments for you if you have an inherited mutation. You may do, you may not, but you might do. Especially with that type of history, you could have an inherited mutation. So we want to know, so we want you to be getting some what they call germline or inherited mutation.
All right, I'll ask the oncologist when I go in to see him. I only talked to him on the computer about 2 weeks ago, but they couldn't schedule me until at least the 10th of June, and then maybe not on the 10th of June. He had a lot of people backed up. I have a feeling that this is a new experimental type of therapy. It's called radiation beam therapy.
No, it's been around quite a long time.
All right.
So now, what type of doctor is this? A radiation oncologist?
It's a radiation oncologist. His name is Dr. Hong. He's at the
Oh,
Virginia Hospital Center in Arlington, Virginia.
okay. So let me throw it open to a couple of the guys who are local to you, and I would like to ask them whether they think this is because I don't know, but I'd like to know whether they feel this is the best place for you to get treated, or, whether you should be thinking about something else. Start with Joel, and then we'll try Herb. Joel, what's your thought on this? Because you know the area well.
Yeah, if the cancer is now in the bone, he certainly would be eligible for SBRT, and he would only need probably 3 treatments of that, 3 to 5 treatments of that.
Yeah, it's not in the bone, Joel.
It's not in the bone.
Oh, it's not in the bone?
No. So he's already had his Axumin. The Axumin scan says it's local, but it's it's evident.
Okay, then the radiation oncologist would know. I know I went to Dr. Eblin that practices in Fairfax, and he does all 5 types of radiation, and he would know which radiation is best to treat that situation. And so for me, it was in the bone, so he decided on SBRT, but he is qualified in doing all the radiation methods. And as far as he is also Eblin has been doing radiation at a Maryland center, and now he does it at the Shar Center. The Shar Center, Innova Shar Center, has a brand new machine as of about 6 months ago. So it's all done locally now. Herb, you might have some more intelligence on that.
Well, I mean, I don't know. I personally would pick a radiated oncologist that specializes in prostate. I mean, I don't think a general RO is the way to go with any of our disease. I happen to think the guy I went to at Georgetown is outstanding. And I had three different treatments there with the CyberKnife, and I thought they did an excellent job.
So let's back up one. Do we think that Harry should be seeking a second opinion? I mean,
yes. That's for sure.
Yeah, and also a GU medical oncologist.
Right.
Okay.
What type of oncologist?
An
GU.
oncologist that specializes in prostate cancer.
Well, yeah, I have, I think I have an oncologist that specializes in prostate cancer. His name is Dr. Fiat. He was the partner of Dr. Lorraine. I have to ask him.
No, Fiat is a urologist surgeon.
Okay,
He's one of my doctors also.
all right.
So in order to find, there is a woman who's pretty good in Fairfax. I can't remember her name offhand. Elizabeth something or the other, is it, Joe?
Dr. Argon Ching, ARAGON dash Ching, CHING. Dr. Argon Ching at the Nova Shar Center in Fairfax. And she has an underling that just started with her in the last 3-4 months. I believe she's also a GU medical oncologist, and her name is Dr. YU.
So I think a couple of things. I think one, we'd be saying, you've got the Acumen scan, go in for a second opinion from them. If you
All
want
right.
a second opinion from a radiation oncologist, we can give you names. What about the option of going to Sibley? Anybody?
Well, if it's an RO, I think Sean Collins at Georgetown is as good as it gets.
Very good, yeah. He's very good. I mean, the only
But
reason
I
I'm
think if I were looking,
because
if I were in this area, and I am, and I needed a medical oncologist, a GU oncologist, which I did, I would go to Hopkins.
well, the answer is yes, but I'm thinking about something more convenient for Harry, and I'm also looking at his stage of disease.
Yeah, well,
and where he is.
Yeah.
And so, whilst Hopkins might be good, I think that a local person might be good, or Sibley might be good because
Well,
you can access.
the deal with Sibley.
Let me finish.
Let me finish. The deal with Sibley is that a lot of the docs at Sibley want to see you first at Hopkins.
Just let me finish. What I was going to say was, if you were to go to Sibley, you could combine the radiation oncologist with the medical oncologist, and it might make it easier. Go ahead.
No, I agree. But as I said, a lot of the docs at Sibley will want to see you first up at Baltimore, and then they'll transfer you to Sibley.
Okay.
But I'll see you all next week. I gotta go.
Okay.
All right. Thank you.
So, anybody else want to chip in with any words of advice, either if you're local to that Virginia area, or if you've got a similar experience where you had seeds or something similar and the disease came back after 4 or 5 years? Anybody have anything they want to, any navigation advice for Harry?
Well, let me say, I asked my doctor what my prognosis was, and he wouldn't tell me. He just said that they have a lot of new medical treatment now that they didn't have before.
Okay, anybody want to address that one? Anybody want to talk to that one?
Well, I think it's kind of good that he dodged. We didn't really dodge the question. I mean, judging from all the guys I've seen in this group, the prognosis is so incredibly variable that I don't see how anybody could, in good conscience, tell you, okay, you have 4 years or whatever, you know? It's all over the place, going all the way up to 20 from what I can see. And in fact, that is true, that there's new treatments coming around every year. So I don't think he really was dodging the question.
Well, I know. That might have been an unfair question to ask him.
You know, I think 5 years ago or 10 years ago, it might have been. I think today, as we say, you've heard, we just don't know. I mean, with disease like yours, that's taken a while to show its face, probably wasn't more than 3+4 in the first place. But you know, that's why you really need to have your original biopsy, because these are important questions. It's most likely something else is going to take you. And you can get, but you have to get really good treatment at this point. And really good treatment means, first of all, having a really good radiation oncologist. And I would agree with the recommendation that Herb gave you, because I know that guy, Sean, what's his name, Connolly, I think it is, and his brother, he's got a twin brother. It's tricky if you've already been radiated, what they can do and where they can radiate, and the extent, and we don't know how much they radiated in the first place. And I think you should get a second opinion from the radiation oncologist, and you should get a genito-urinary medical oncologist, a prostate cancer medical oncologist involved. And I think if you take those two pieces of advice away, and we'll keep helping you. We can help you find these people. We can provide support. There are local people who you can ask if you've got questions. But I think the outlook is positive. And you should come away from feeling good about where you're at. Of course, nobody wants recurrence, but it's very, very treatable. We've just got to make sure you get the right treatment, and it's not just a slam bam, thank you, Sam.
Isn't it true the older you get, the slower it grows?
It all depends on the disease.
All right.
If you never had prostate cancer, it's true. But if you've got prostate cancer, it's a function of the cells that you have, and it's different for everybody.
I was told originally I had a very aggressive prostate cancer.
Well, if it was very aggressive, they should have kept you on hormone therapy for longer than one shot. And that's what leads me now. That shot could have been a 6-month shot at the time, or it could have been a 3 or a 4-month shot. But in my case, I was on for 28 months with similar treatment to yours.
Yeah, I think the problem was that my original doctor died.
Well, that's not necessarily a problem. It's a question of whether he treated you right in the first place.
Yes.
Right? That he
I
died,
guess so.
We can't blame him for that. That wasn't his fault. At the same time, we don't know what treatment he had, because you're not sure of your Gleason. You didn't get your records, and we
No,
don't
I have
know.
to go back. I have to go back and get my records.
So, we're going to have to move on because of this time crunch. But Harry, now you got the score. You can come back on Monday or next week, and you can tell us what you've done. But I really would encourage you, check out this lady, Argon Cheng in Fairfax. And I will send you, I've got your email address. I'll send you the name of the oncologist, Sean, what's his face, that we like. Jerry Deans, who spoke with Blee, also saw the same oncologist, and I've heard him speak. So we'll get you that name, but I wouldn't, it sounds like they want to rush you in. I would say take your time. Are they talking about putting you back on hormone therapy?
Yes, you're going to put me back on hormone therapy after they do the radiation.
Well, again, I've been asking her why she's not doing that before you do the radiation, because it weakens the cells.
I don't know. I don't know that much about this.
That's why you're here, and we're going to make you your best advocate.
Okay.
So we're going to tell you the questions to ask. So, questions to ask her that you have right now, and you can send them to her tonight, are number one, what's the field of radiation, or what are you going to radiate? And number two, why are you not putting me on hormone therapy before you start the radiation?
All right, I'll ask those questions.
And come back and tell us next week.
And
Okay?
I'll come back and tell you what I find out. And I'll try to get my records.
Okay.
This,
All right.
This is John again. Could I just make a brief comment? Something that I learned from the guys in this group that's been very helpful to me, because I used to look up my prognosis and get all depressed. But now that you're recurrent, and now that there's all these new treatments, the guys have taught me to think of my cancer as a chronic disease that has to be managed. Almost in the same way that diabetes is a chronic disease that has to be managed. And yes, it can kill you, but it can be managed for a long time. So it's been helpful for me to think of it that way instead of to think how many years that I am likely to have left. And I have the guys to thank for that.
That's a good idea. That's a good way of thinking of it.
Thank you, John. All right, I'm gonna run down. I'm gonna run down and see who needs time today. We may not get to everybody. We've got 50 minutes or 45 by the time I'm done. So I know that Stan definitely has something on his mind because he mentioned that to us before. Let me keep going and see who else. Jake, anything for you today?
Nothing for me. Thanks, Rick.
Peter Monaco, anything for you?
Yeah, Rick, I need a little bit of time tonight.
Okay. Ted Healy, anything for you?
I'm good, Rick. Thank you very much.
Thank you. Jim Marshall, anything for you?
Negative.
Thank you. Joel, anything for you?
4 or 5 minutes.
Okay. Jeff Marchi, anything for you?
Not today, thank you.
Thank you. Don Price, anything for you?
Oh, thanks, Rick.
Dennis Correa, anything for you tonight?
No, thanks, Rick.
Ben, anything for you?
No, thank you. Was that Ben or Len? Or
That
Ken?
was a Ben with a big.
No, thank you.
Okay. Jim Barnes, anything for you?
No, I don't think so. Thanks.
Thanks. Pat Martin, how about you?
I'm good, thanks.
Julian, anything for you?
Just a minute or so.
Okay. Peter, anything for you?
No, maybe Monday. I have a face-to-face with Schultz on Thursday.
Oh, okay. So maybe next week. Wait a minute. You're in the chair. Are you allowed to ask yourself?
Sure.
Okay.
I talk to myself all the time.
Okay. Well, if you're in the chair on Monday, we'll make sure you give us a report because I won't forget. Okay. Larry Fish, anything for you?
No, thank you, Rick.
Dennis McGuire, anything
Hi,
for
Rick.
you?
Hi, yes, I have an update.
Okay, great. John Ivory, anything for you?
No, thanks.
Joe's gone. Les Shelderup, anything for you tonight?
No, thanks.
Okay. Paul Frieder, anything for you?
Nothing for me tonight, thanks.
Okay. Dr. Carlos, anything for you?
No, thank you.
Carl, anything for you?
Not tonight.
Len, anything for you?
No, sir. Thank you.
Okay. Jim Jeffries, anything for you?
No, Rick, I'm going to drop off and go on the sarcoidosis meeting.
Oh,
But
okay. Give
thank
him
you.
my best and tell him I'm busy tonight.
Okay, I'll tell them you got a full house. Take care. Thanks,
Thank
everybody.
you.
Bye.
Gaoshan, anything for you? Gaoshan? Okay, we'll come back to Gaoshan. It's still showing red. John, hey, anything for you? John?
You're muted, John.
Sorry about that. I was late, so just only if there's room at the end, call on me.
Okay, if not, we'll handle it tomorrow at lunch. Okay?
Oh, yeah, okay.
Okay. All right. So, how many do I have? 1, 2, 3, 4, 5, 6. 6. We got a shot at getting through
You
every.
missed me, Rick, Jerry Pelfrey, but I'm okay. Nothing tonight.
Oh, sorry, Jerry. I actually had a tick by your name. I wonder why that was. Oh, I know why, because Julian. Sorry, Jerry. My apologies. All right. Did I miss anybody? Oh, Mark, Dr. Mark, I didn't put you down. Nothing for Dr. Mark. Did I miss anybody else? Okay. All right. So and forgive me if we cut off some of these a little quickly, but I would like to try and get round to everybody. Why don't you update us?
Who?
Dan.
Oh,
Dan the
sorry.
man.
Sorry. So last week I had a meeting with my radiation oncologist at Sloan. He is recommending a 4-week course, the implantation of fiducial markers, and a 4-week course, 5 days a week of low-dose image-guided radiation. I asked him about stereotactic versus image-guided, the addition of brachytherapy along with the external beam radiation, pelvic girdle radiation, and rectal spacer gel. In each case, he tended to feel they weren't warranted, that they introduced an added level of risk to where I was currently in terms of potential adding to any side effects I might have from the radiation. I just wanted to get a feel for how the guys feel, particularly in terms of the use of a rectal spacer gel, all right, which can be done at the same time as the implantation of fiducial markers.
Okay.
And whether that's really of significant benefit, and whether I should.
What is a rectal spacer gel?
It protects the rectum during radiation.
All right.
Okay. So let me ask you, Stan, again. What is the field of radiation that he's looking at?
He's just looking at the prostate area.
And why does he think that? I mean, you have never had. You've never had radiation before.
That is correct. I've never had radiation before, so he feels basically that he can come back. My everything, the ADT seems to be working. My PSA now is down to now 0.06. There seems to be some bone healing, and there seems to be some partial healing or a reduction into where they previously detected outside of the pelvic area into the lymph nodes of any cancer. So if anything, it seems to be receding back into the, I wouldn't say receding, probably a bad word, but it looks a lot more contained. And what he's saying is we can go back at it at the more appropriate time. This is not it.
Well, and you said 0.06. Do you mean 0.6 or 0.6 or 0?
I'm sorry, 0.0. My PSA now is 0.06.
0.06.
Correct.
Okay, because it was at the beginning of the month. It was 0.34. It's now 0.
No, it was. Yes, correct. It was 0.34. 0.34. It's now 0.06.
Okay. So again, if it were me, I was going in for it, I'd have them, and they'd seen disease in the lymph nodes. I would If it was me, I would want them to radiate the whole pelvic girdle. I don't see the downside to it for me. For me, there wasn't. I mean, I don't think that there's significant downside to it. And I don't understand the reluctance. But it's, you know, again, that's up to you, but you're asking what the guys think. Since I had that treatment, not for recurrence, I would definitely look for it again if they were going to radiate now, let me just check one thing with you. You still have your prostate, right?
That is correct.
So basically, this is the treatment. This is treating the prostate gland.
Correct.
So, yeah, I mean, it's typical that they don't. I know that Ken Anderson, they did not radiate the pelvic girdle. I don't get it why, and if it were me, I would do it, but what about some other people? What do the rest of you think? Well, who else has had their, Herb had his, I know Herb did, but he's left us today. He's busy giving he's giving weather reports to his sailing friends. Anyone else have their prostate gland treated after they were diagnosed metastatic?
Yeah, Rick, I did. But I don't know the history for Stan, or I don't remember it. What's his Gleason, and what prior treatment has he had? I presume you're on hormone therapy now.
That's right. My Gleasons were 8 and 9. All right, about out of 10 out of 12 core samples. Basically, I'm on Eligard and Xtandi.
And for how long?
For now, well, I started with abiraterone. Didn't work well with my liver, so together between the abiraterone and the Xtandi, it's been about 3 months, 3 or 4 months.
So your doctor doesn't want you to do anything now, is that right?
No, he wants me now to follow up now with the radiation.
Oh. Okay, so what is the issue?
So the issue is, should they treat the prostate gland alone, or should they treat the prostate gland and a wider area?
Yeah, with a Gleason 9, I think I would, if it were me, I would prefer that they did the entire pelvic region. You said you had evidence of positive lymph nodes or anything outside the prostate?
Yes, yes.
Yeah, sure. So, like, why wouldn't you do the full pelvic girdle?
Yeah. Okay. And what about? Has anybody had any experience with the rectal spacer gel?
Well, I had that also. And I had very high dose radiation to the prostate and the pelvic girdle. And for 18 months, everything was copacetic. But then slowly I started seeing some blood in my stool, to the point where this Thursday, I'll be going to Weill Cornell to have an argon plasma treatment. So did the spacer fail is the question, and the answer is a little more complicated than it might seem, because I had the spacer gel inserted, and normally they would go ahead and radiate within a week or so after that. But due to the fact that my radiation oncologist was switching offices, he wanted me to wait until he got to his new office, where he said the equipment was newer, and it took longer than he expected. So it was over a month that the spacer gel was just sitting there, and that was probably the best time to be protecting the rectum, but I wasn't getting radiation. So and then I had 9 weeks of radiation following that. So I'm wondering if maybe I had lost some of that spacer gel. It had resorbed before the radiation finished. But I mean, I'm glad I had it. I would recommend it.
Okay. Okay.
Anyone else on either of the two issues, the pelvic girdle, the radiation field, or the spacer gel?
So I had a radiation SBRT ending, for 6 sessions around Thanksgiving last year. I didn't have any space there inserted, and they just made sure that I had my bladder full when I showed up for the radiation. So that was it. And in terms of radiating the entire pelvic girdle, I asked the radiation oncologist that, and he said he wasn't going to do it. I didn't push it because I didn't feel that knowledgeable, or that it needed to be done. I figured he had his reasons for not doing it. But last we met, or a couple weeks ago, I said I was having some pain down in that area in my pelvic hip, and I had an MRI completed last week, and it showed no metastatic spread of the disease anywhere in soft tissue or the bones. So I was happy to hear that. There was some sort of Tarlov cyst in my spine that they feel like might have been pressing on a nerve, causing some of my problems.
Okay. All right.
So look, I guess the way that I look at it, that it doesn't have an awful lot of downside if they're radiating across the pelvic girdle. I don't know too many people. I mean, I know a few people that have had some what's the word I want? Not lymphodectomy. They had swelling of the lymph nodes, lymphedema. Right, docs? I'm looking at Carlos and I'm looking at Mark. Lymphedema. So I know some people have had some lymphedema, but it's pretty rare. And the gel is really more about radiating the prostate than it is radiating the pelvic girdle. That's where the gel is going to protect you. I didn't have the gel because it was barely available at the time. Plus, my doctor didn't support it. I've heard some of the guys on some of the other calls bitch and moan that it's painful when they put it in, but I've never heard that from anybody that's on our call. So I think the gel is your call. I mean, they're both your call. The gel, I'm sort of, the jury's out. But I do think that it's better to be safe than sorry, and I would want them to radiate the whole pelvic girdle.
Okay.
So you say
I'd be going for a second opinion.
You said there's no downside to the radiation with regard to the pelvic girdle or bones. My radiation oncologist didn't want to treat the spot on my spine on my back because he wanted to maintain the integrity of that bone. Does radiation in any way impact the bone density or bone structure?
So again, yours is a different situation, and this may be the situation with Stan, because Stan does have some bone mets. So Stan may not be a good candidate for pelvic girdle radiation. And you may not have been a good candidate for pelvic girdle radiation because of the location of the bone mets. So that's something that's way above my pay grade. But for somebody that doesn't have that type of complication, I would say to do it. But again, I've got to cut this off at this point.
Okay, not a problem. You've given me enough to chew on. Thank you.
Okay. And if you want to talk to anybody on the call, Stan, reach out to me. I'll connect you.
Great, Rick. Thank you.
Okay, let's go to Dennis McGuire.
Hi, everyone. I had my third treatment of lutetium last week. Also had scans and a PSA test. And I continue to have a positive response from the lutetium. My PSA last week declined 50% from 6 weeks ago. So since the day I started treatment, my PSA is down almost 75%. And the scans kind of confirm that.
25? Where are you? 25?
So I'm at, yeah,
Sorry?
24.
24. Okay.
And the scans are showing that the lymph node mets are decreasing in size.
Great. Great, great, great.
So hopefully it continues to work and brings those mets down even further.
That's great news, Dennis. Congratulations.
That
Yeah,
is
thank
so
you.
good, Dennis. I'm really happy. How about you? How do you feel about all of this?
I feel great about it. I mean, I think it exceeded my expectations.
Wow. I mean, I'm so happy for you. But now you're done now, right? This was a
Yep.
3-treatment
That's right.
trial. So, can it continue to work?
I think, yeah, they do think it has a lasting effect. So it hopefully will continue to work. I did ask about potentially doing another treatment. I certainly cannot do it on trial.
Right.
Because the trial has a strict protocol of 3 treatments. So we'll just have to cross that bridge when we get to it. We'll see how I respond, and if we need to continue treatments, we'll see where that goes.
And where are you now? Just on an LHRH?
Yes, Lupron.
Okay. Wow. Well, okay, guys, so here's an example of lutetium doing what it's supposed to do. Anybody want to talk to Dennis?
Yeah, Rick, I'd like to, first of all, congratulations, Dennis. I'm glad
Thanks,
that
Len.
it's working so well. I know you've had some previous failures of treatment, so you were due a success here. That's great. Just watching your tongue kind of circulate through your mouth there, are you experiencing some dry mouth? And did they tell you that you'll recover from that?
Yeah, I do have some dry mouth the first week after treatment, which I'm in right now. But that subsides, hopefully. You know, I think that's one of the concerns about the number of treatments is getting too much of the radiation and what the lasting impact could be. So that's why, you know, I think when I spoke to the doctor, he was say, you know, let's pause, let's see how you continue to respond and go from there.
Do they give you any medication to stimulate saliva secretion? Or...
No, it didn't really get to that level, Len. It just, I think it just makes me stay hydrated. Just, you know, continually drink during the day, and the worst part is in the morning, obviously.
Yeah. Okay, continue. Good luck, brother.
Great.
Yeah.
Thanks, Len.
We hope it keeps, I hope this is the gift that keeps on giving, Dennis.
Thank you, Rick.
What we really,
Hey, Dennis, this is Carlos.
Hi.
I had a question. Have you heard of something called liquid spit?
I have not.
Yeah, look into that. It's supposed to be something that's a little more viscous, stays in your mouth a little longer, helps with that dry mouth.
Okay, thanks. I'll look into it.
Is it over the counter, Carlos?
You know, I only have heard about it. I don't really have any more details, unfortunately, but I'd like to know myself just in case I ever need it.
Okay, we're assigning that duty to Dennis McGuire to research it.
Yeah. Oh, incidentally, on that topic, one of the follow-up scans, which is going to be in a month, is a scan of the salivary glands.
All right.
So
Okay.
they're going to check and see what they look like compared to baseline before I started treatment.
That's interesting. Yeah, I mean, I can see that as part of the trial. I can see how important that is, definitely.
Yeah.
All right. Anyone else before we move along? Okay, let's go to Peter Monaco.
Hi, Rick and everyone. So not a good development for me. Recently, you may recall in my last update, I advocated to get my oncologist to order a Asmin PET scan for me, which I did get last week, and things showed up. Some bone lesions showed up, and some suspicious lymph nodes in the clavicle area. So wasn't the news I was hoping to hear, but I got to hand it to you, Rick. You were right. You said this last year. With my PSA jumping up the way it was, you were pretty confident that there had to be something going on. And indeed there was. My oncologist's opinion that I was still micrometastatic was obviously quite wrong. So her path of action now is to have me on hormonal therapy forever. And that's the only update I have from her. I've been listening and hearing people say there's opportunity possibly to do some SPA radiation when you have spinal mets. I don't know if that's really what I heard, but I'd be curious to know if there's something like that available, or am I just going hormonal therapy until it's effective or until it's not effective? Let's put it that way.
So where are the bone lesions that showed up, Peter?
T2, T11, L5, iliac, posterior right iliac bone, and also the clivus, which I don't know where that is.
The where?
Clivus, Clivus. Don't know where that is.
Okay, who's going to tell us? Either Carlos or Mark? And they're both throwing their hands up in the air. That's not doing us any good. Come
They're
on.
Googling it. They're Googling it.
Oh, they're Googling it.
Cranium. Bony part of the cranium at the top base.
Cranium. Okay.
Bony part of the cranium at the skull base.
Okay, base of the skull, skull base. Yeah, that's
Clivus?
a known spot, shall we say. Well, I have a couple of ideas. First of all, I don't love these docs that say, well, we're just putting you back on ADT forever.
Yeah, that's it. That's the course of action. I'm on Lupron and Casodex right now. I started last week, and that's the course of action. You know,
how many Mets do we see in total? 5 or 6?
I'd say 5.
5.
Yeah.
Well, I think for those of you who have been with us a long time and know Peter well, and we love Peter and we can't do without him, none of us are too thrilled with Dr. Zhao, nor have we ever been.
Yeah.
And, you know, I think that probably now is as good as ever a time to think about making a permanent change.
Yeah.
I think there are options. What you probably don't want to hear come out of my mouth, but it will, is that chemo is a real option for you now, and probably the earlier you do it, the better it is, and you may be able to really whack that disease hard with 5 or 6 sessions of docetaxel. And I would want to be, A, I'd be wanting to talk to the doc about it, and B, if it was me and Dr. Zhao, I would have already asked her, why have we had this discussion? Why are we not having this discussion? You know, I know you've seen Patel at Mount Sinai.
Yes.
And we do like Dr. O, and Patel works very closely with Dr. O. This woman seems to be a bit of a loose cannon. And so, you know, it's not fair to say you would never do anything else, because you could knock this back with chemo and 18 months of radiation and of hormone therapy, and 6 months from 2 years from now, you could be on a holiday again. And we don't know how you're going to respond, but we've seen other guys that have responded well in that situation. I'm going to throw it out and see what the other guys say.
So I was going to mention that, first off, I think in this day and age, with the new cardiac information, people on Lupron should ask their doc and have a serious discussion about whether they should be on an antagonist versus an agonist. It doesn't mean everybody needs to switch, but they do need to have that discussion. Castrate-Resistant is a much older receptor blocker, and I think we rarely see that used, maybe in the first month in someone who's just getting ADT when they're starting Lupron, but an ongoing, excuse me, on an ongoing, someone else take over, sorry.
Yeah, well, Mark, we'll come back to you. And I agree with you on the Castrate-Resistant, that if they were going to pair it up, why she chose to pair it up with Castrate-Resistant is tough for me. Anybody else have any thoughts on Len? I mean, what are your thoughts? What's your thoughts on chemo?
I just recently met with Dr. O, and we just had a wide-ranging discussion. One of the things he mentioned is he thinks chemo is underutilized. So I'm sure if you were seeing Dr. O and you're seeing Dr. Patel, so I guess you can say you're seeing Dr. O as well, they would probably recommend chemo. Seems like a good option. And
yeah,
did they tell you that you were only going to be on the Castrate-Resistant for a couple of weeks to block front flare?
No, before we had the PET scan, Dr. Zhao had said that I would be on this dual regimen of Castrate-Resistant and Lupron for 12 months. That's when I insisted that she ordered me the PET scan, which she did. And then I saw her last week when we had to discuss the results, which, you know, obviously came back with a lot of positive hits. And then I said, so what changes? She said, you'll be on the Lupron. I'm assuming she would mean Castrate-Resistant as well, you know, indefinitely now. My patients may ask for a break every once in a while, which I'll let them do. But basically, she was leaving that up to the patients. But generally, it was like, you're in it forever now. So,
as Mark was saying, Castrate-Resistant is an old drug. It's not as effective as the newer glutamides. And at some point, it often converts from an antagonist to an agonist and helps your prostate cancer grow. So I would get off of that. If it were me, I would get off of that as soon as you can, and have a discussion with your doc about either Xtandi or Zytiga or apalutamide. I mean, if you can get darolutamide, that'd be fantastic. But
And these are with in tandem with Lupron, Len?
Yeah.
Yeah. Right.
I mean,
Well,
that can go on while you're getting chemo as well.
oh, you can do all three.
Yeah.
This is Jake. I'm not disagreeing with anything that anybody said about Casodex, but I was on it for 415 days, and it kept my PSA, it knocked my PSA down in conjunction with Lupron for about a year, maybe a little bit longer. So it does work. But like Len says, you do have to watch it because it can also turn on you. You need to get PSAs every month for sure if you're on it, and be careful because it can start raising your PSA. Just my 2 cents.
Yeah,
I had this experience with Casodex. My Lupron stopped working for me, and I went about 16 months adding Casodex, and my PSA stayed down for about 16 months, and then it started rising again, so I went to abiraterone. But I know somebody else who is taking it has Casodex off and on. That's all he takes. Every couple of months he goes on it and off it, and has been doing that for years. It just, his doctor didn't like the idea, but it seems to work for him. So you never know.
Well, just final update for me. I do have an appointment with Dr. Patel on July 16th. I don't know if I should move it up, if I could. I have a hard copy of the report. I don't have the CD. I don't know if he would need to see that, but I was thinking of sending him a scan of this report in advance of my meeting with him, and I may make the change when I discuss with him, like, what do you think? What's your opinion of my situation and how best to proceed at this point? Does that sound reasonable, or should I be moving that up? Because I'm with you. I mean, I agree with you. I hate to. I hate to be critical of medical professionals, and I do believe Dr. Shao is quite professional. But I just, I'm troubled by, that she wasn't going to order the PET scan. It was because I insisted. Otherwise, maybe, I don't know, maybe I was better off, ignorance is bliss, because the CAT scan and the bone scans that she ordered were clear. So I'm thinking, maybe she's right. Maybe I'm micrometastatic. But,
Look, Peter, she was slow on the uptake last year. She didn't follow through with the sort of scans that we would hope she would have done. And when she did, she's still dragging her heels. And the minimum standard of care would be Lupron plus either abiraterone or enzalutamide, probably abiraterone. And it may also be Lupron and chemotherapy followed up with another one of those second line later. I mean, that's what the NCCN would recommend. None of the options would be Lupron plus Casodex at this point in time. So my feeling is that you do move it up, send your scan, get a copy of the disc or get a copy of the link so he can download it, send it to him and move it up and say, I've got multiple bone mets and I'm trying to figure out what to do. I don't think I'm on the right treatment, right? I'm on Lupron and Casodex and I don't think it's the right treatment.
Okay.
And let's see where we go from there. But I don't get Lupron and Casodex. I mean, that we know per NCCN guidelines is not the optimal treatment.
Well, how is this possible? I mean, this is Sloan Kettering we're talking about here. This is like the go-to place. I mean, look, it seems.
Peter, you met the enemy. We've been saying that this woman's behind the 8 ball for a long time. It's clear the way she's been treating you. How did
You know,
she get away? How does she get away with it? I'll tell you how she gets away with it. Nobody looks over her shoulder. Nobody challenges her. She does what she thinks is right, and that's it. But if you're your own best advocate, you challenge her. If it were me, I would have been challenging her a long time ago. You're a nicer guy than I am.
you know, I'm old school in that I you know, give doctors, you know, a lot of credibility. Sometimes it's not well, you know, well seated. So I think that I was probably
Peter, I'm looking at my notes here. And
yeah
I put a note from September of 2019
yeah.
that says your PSA has gone from 0.79 to 1.45, and she did not offer you an advanced scan.
And I was probably those Mets were probably there at that time. Wouldn't you agree?
Right, and we said to you change, and it said, and I got staying with Dr. Zhao and Baskin Ridge. So
yes, that's right.
You're right. Yeah, the water.
I want to say something about the way the doctors work at Sloan and the Sloan satellites. That I had a long conversation with my oncologist at Sloan about this, who works, you know, in research with Radcliffe, and she said that in general, once you're a patient of an oncologist at Sloan, that doctor is working with you, and that's not something that is discussed in grand rounds or in groups, unless that's a special or unusual case where the doctor decides to bring it up. So I know that I'm working with my doctor, and then she's not really talking to anybody until I'm unhappy. I'm not going to worry about it. I'm happy. But in a case like yours, where you're saying, why doesn't it happen? It was Sloan, for God's sakes. Because nobody's following, like Rick said, nobody's not just looking over your shoulder. There's no one paying attention besides Dr. Zhao, who you're seeing, to exactly what you're doing, as long as nothing really horrible is happening and she's not referring it to a discussion when they meet in group or they discuss with other docs. So your case may be more or less, for her point of view, kind of typical, and she follows with the protocols, the procedures that she follows, and no one else is hearing about it or thinking about it. That's probably what's really going on.
You know, from my perspective, something horrible is happening. I mean, I'm going along fat, dumb, and happy here, thinking, oh, I'm micrometastatic, I'm biochemical, and meanwhile, I've got, you know, bone mets all over the place.
Right. We've got to cut this off.
Okay. Well, thank you. Thank you.
I want to get to Joe, but please get your ass out from under Dr. Zhao at this point.
I'm in or I'm out, depending on how you look at it.
Okay.
Just a quick comment. Isn't it telling that
John, I got to cut you off. We've got 7 minutes
Go
left.
Go right ahead. Yep.
Joe Blanchette, and I would like to try and get to you and others too. Joel, what's up?
Okay, I've had a bunch of PSAs here, and let me read to you what they were. I basically, until 8 May 2019, it took me 8 years to get to 0.04 because it was pretty much running sideways. 3 months later it was 0.07, 3 months later it was 0.09, at which I entered the clinical trial at NIH for the PSMA PET scan DCF-PYL. 3 February 2020, it was at 1.26 on my first day of SBRT to my left iliac bone. I had 3 treatments. On 10 March, because of the PSA flare, it was up to 1.76. On 10 April of 2020, it was down to 1.3. 12 May was down to 1.0. 10 June, it was 0.862. 12 August, it was 0.814. And then I went to see my hematologist who gave me a PSA. And because he switched labs, like Dr. Mark told me, if you switch labs on yourself, you're going to end up with a 15% delta between and so lo and behold, LabCorp went from 0.814 to 1.03. Then Dr. Quest, I went back to 0.08 in October and November both. February 2021, I was at 1.0. And again, LabCorp produced on 28 March 2021, 1.39. However, I switched urologists, and the urologist has an ultra-sensitive test. It was back down to 9.3. And then on 21 May, I said, well, let's take a regular Quest test, not an ultra test, because that's a different lab in California instead of New Jersey. So I'm back down to 0.9. I presented all of this to Dr. Antonarakis, and let's see if I can put it in chat here. And he came up with a statement for me. I can't put it in chat for some reason. But anyway, let me read to you what he said. Very short. I'm convinced that your PSA level is rising. It seems pretty stable, is not rising. It's pretty stable to me. In my opinion, it's too early to get a CT scan or bone scan. Also, I would not travel to California for the PSMA PET scan because I anticipate that this will be available soon on the East Coast by June or July this summer. My advice would be remain patient and get a PSMA PET scan locally at Johns Hopkins as soon as it becomes routinely available. So that's basically saying that because my PSA is really ticked down to 0.9 instead of, I really expected it to go up to 1.3, 1.4 with Quest, but instead it went down to 0.9 for the sensitive test and for the regular test. So, according to Dr. Antonarakis, he says, hold on, let's see what happens. My next test will be in August. And I know that California, UCLA, and UCSF have jacked up their prices on the PSMA PET scan to $3,300 from $3,000 now. I think that's their fourth increase. Also, according to Dr. Michael Morris of Memorial Sloan Kettering, he says that the FDA has now approved PSMA PET scan separately, and you don't have to take a CT scan and a bone scan with it because the FDA recognizes.
Joel, let me cut you off because we don't have a lot of time. I want to make sure you get some feedback, okay? I'm listening to you, and what I'm hearing is that your PSA started to increase fairly significantly, and you did some SBRT, and when the dust all settles, then you will be the PSA has gone back down to that 0.8, 0.9 level. And I think that's what Antonarakis is saying. Now, what I don't understand, and why did nobody ever say to you, why don't you just go get an Axumin scan? It's not expensive, it's available, and your PSA is at a high enough level that you're going to get a result. It's all well and good saying, yeah, the PSMA is great and it's much finer and what have you. It is. But there are in certain circumstances, an Axumin may be as good. If you're at 1.5, I would definitely say. At 0.9, are we going to see as much? Maybe not. But we know that these PSMA scans are going to be available very soon. Now that especially with the last approval, and you'll be able to get it locally, and it'll be Medicare. And in the meantime, if you're worried about where it is and you want to start working on it, get an Axumin scan. I mean, does any of that not make sense?
I think it makes a lot of sense. I'm going to do that.
And, you know, if we don't see anything on the Axumin scan, then I would say, okay, we've definitely got to get a PSMA and we'll stay in this holding pattern. But let's see what an Axumin can throw on it. It's not hard to get now. They're available everywhere. And as you heard today, we've had guys that have gotten significant results out of Axumin scans. So to me, anyone else want to come back on and add anything to this?
Yeah,
Nobody?
basically, Dr. Antonarakis is disregarding the LabCorp test, basically, because they were much higher than the regular Quest test. So he's choosing to go strictly with the Quest.
Yeah, but you know, and you know this as well as anybody. I mean, we're not looking at absolute numbers. We're looking at trends. And he's drawing lines through to see where that trend line is going. And it makes a lot more, it's a lot more important to get something, to get a test from the same lab when you're looking at first recurrence after a radical prostatectomy. But when you've been out as long as you have and things are going up and going down, and even if we adjust for the 15%, we're just trying, what we're trying to do is say, which way is it heading? Is it heading up? Is it heading down? Or is it heading sideways? And he's comfortable enough. Now, what do we know from this? There's something going on. We know there's something going on. Then the question is, where's it going on and what do we do about it? Which is the conversation we just had with Peter, Monaco. But we don't have enough information. And that's why I'd like to see you get a, if it were me, I'd just say to heck with it. I'll get an Axumin, and then if it doesn't tell me anything, by the time I've done my Axumin, maybe I can get a PSMA scan.
Yeah, Antonarakis will bless it as soon as I pop up above 1 PSA.
For what, bless what, a PSMA?
A PSMA, another PSMA scan, correct.
Okay, well, get an Axumin whilst you're waiting. Please God, you'll never pop up against over 1, and you know, but get to put your mind at rest, get an Axumin.
Makes
I
sense.
had a maximum scan at 1.1, and it showed 3 lesions. So 1.1 is good to get an maximum.
They say, you know, above 0.85, you're good, and so you're right at that level.
Right.
Mark, you're sounding like, I know you may still be in LA, you're sounding like Mickey Mouse there. I don't know what that was.
I think he took some helium, Rick.
Helium? You have like a helium voice.
It could be helium.
Guys, look, it's 3 minutes to 5. I've got to shut the room. I'm sorry, I've pushed it as far as I can go. John, we'll sort out what was on your mind tomorrow. Everybody will be back on Tuesday. Got to shut the room. We'll be back on Monday, and Peter will be in the chair. Good night, everyone.
All right, goodbye.